Well, hello everyone. So I see some familiar people on here. So some of you may have heard me talk about these things before. And I apologize in advance if it's a repeat for anybody. But what we're going to go over and thank you for having me for this lecture. So we'll go over just some basics of breast anatomy, things that can make you high risk breast cancer screening, the treatment of breast cancer, and then we're going to talk about survivorship a little bit, and then I will turn it over to people who can help you with some survivorship. So the holistic part of it is at the end. Mine's sort of like the more academic part of it. So pictured here is just some basic anatomy of the breast. And so this is looking from the front, and then this is looking from the side. And I just need to minimize, there we go. Lots of faces on the side of my screen. So this is just, as I said, from the front and from the side here. And essentially what the breast is made up of is your the ribs are in the back, pectoralis muscle. And then can you all, I'm hoping everybody can see my mouse moving, but then the breast tissue, oh, hello, that wasn't supposed to happen, is made up of breast tissue, the lobules, and the ducts. And so the lobules are where the milk is made, and then the ducts are the pipes that bring the milk out to the nipple. The other part of breast surgery and breast cancer is that you have lymph nodes. And so you can see these little green lymph nodes underneath the arm, and also some to the medial side or the inner side of the breast. And lymph nodes are in our body for the most part to help us fight off infection. But they're also really good at filtering cancer. And so not just breast cancer, but other cancers as well will get filtered through the lymph nodes and help to prevent spread to other parts of the body by acting like a big filter. So that's where the lymph nodes are when we're talking about lymph nodes and staging. So what we'll talk about first here is how to do a breast exam. And so there's lots of different ways to do it. And actually the American Cancer Society a couple of years ago stated that they no longer recommend monthly breast exams, but what they did recommend is being familiar with your breasts and knowing what to look for. And so, I don't necessarily agree with that. I think it's important to know that if there's something there, and usually if you can do a monthly schedule, it allows you to find things. But there's different ways to feel, up and down, radial, meaning you start in the middle and go out, or you can do a spiral method for anybody who's my patients. I use the spiral method. But really what's important is looking. And a lot of us don't look at our breasts, but when you step out of the shower each morning, or well, you don't have to do each morning, but about once a month, just take a look. Again, for those who have been in my office, I have you put your hands on your hips and put your arms up in the air to see if there's any pulling or tugging or obvious masses. Other things you want to look for is if your nipple is pulled in, any skin dimpling, any dripping, any redness or skin changes, and you want to report those to your physician. So again, here you want to report new masses, nipple discharge, whether it's, what you want to report is spontaneous, bloody, or clear. Anything milky, we don't worry about. Anything that you have to squeeze out, we don't worry about. So really it has to come out all by itself. Any changes to your skin, whether it's redness or swelling. If you do have a family history of breast cancer, you want to report that, and any new pain. Pain and tenderness in the breast is extremely common around your period, mostly in the upper outer quadrants of the breast. And so that's common and for the most part is not associated with cancer. In young patients, most of the time it's not cancer. And usually we can find fibroadenomas, which are completely benign lesions. That's a picture of one over here. They're sort of like long and skinny. Cysts, which are fluid-filled sacs, again, benign. Sometimes it's just some dense breast tissue. And what that means is that there's an area where there's lots of breast tissue in comparison to the fat in the area. Abscesses or infections. And then what's important is if you're under the age of 30, you shouldn't be getting a mammogram. Your breasts are too dense, so there's too much breast tissue, and we get what's called, and I'll show you some images later, essentially like a whiteout effect, where we can't find cancers very well. So we usually just start with ultrasounds in patients who are under 30. So there's actually a lot of controversy about breast cancer screening. You might see from the American Cancer Society that their recommendations, and those come from the United States Preventative Task Force, which did a study, I think it was 2009 or 10, that looked at the cost of screening mammogram between the ages of 40 to 45, as well as 45 to 50, and then above 50. And they came out with recommendations to not start until 50 and then to go every other year. Which was, interesting to a lot of physicians, that we were very concerned about the patients between 40 and 50 who weren't getting screened. And so all of the major societies in the United States, the American College of Radiology, American Society of Breast Surgeons, and the American College of Gynecology, Obstetrics and Gynecology, we all have the same recommendations to continue starting at 40, because ultimately the physicians do not care about the $8 that we'll save per mammogram by not screening people between the age of 40 and 50. We'd much rather catch cancers early. And ultimately, what they didn't look at when they did those studies was the cost of delaying a breast cancer diagnosis and the increased amount of treatment in regards to radiation and chemotherapy that would happen with a delayed diagnosis. So for us, it's more important to diagnose early. And so we recommend to Capitol Health, as well as those major organizations, to start your screening mammogram yearly at age 40. If you do have a first degree relative, which means a mother or a sister, you want to start 10 years earlier than their diagnosis. And then if you have a mutation, a BRCA mutation or other genetic mutation, you want to start screening at 25. Usually what we do is we start your MRI at 25, again, because mammograms are difficult to read before age 30. So we start with an MRI, and then starting at age 30, we start with a mammogram, and we alternate those so that every 6 months, patients with mutations are getting studies. So that we catch cancer early. And that's really what the gist of all of this is to catch cancer early. Also, if you have a very large family history and a lifetime risk greater than 20% based on that family history, it's a similar screening to a mutation, but we start at age 30 and then we alternate mammogram and MRI. So what can increase your risk of breast cancer? The two biggest risk factors for breast cancer are being a woman and getting older. So increasing age. If your ethnicity, Ashkenazi Jewish descent, so that's any European Jew, has an increased risk of breast cancer. Increased BMI or weight, and alcohol consumption, and all of those two things are related to increased circulating estrogen. So the higher your weight, the more alcohol consumption, the more estrogen you have, which increases your risk of an estrogen positive breast cancer. If you have a history of either current or prior use of hormone replacement therapy, either estrogen or progesterone, that can increase your risk. And then your reproductive history. And again, this all goes back to your overall estrogen exposure in your lifetime. So a younger age, menarche means when your first period was, so younger age at first period. Nulliparity, meaning that you've never had any children or a low number of children. Older age at first live birth, me. So I had my kids when I was older, and then also older age at menopause. So the later you go through menopause, the more estrogen exposure you have in your lifetime. Other things that can increase your risk are things that we find under the microscope by doing biopsies. So atypical hyperplasia, so overgrowth of funny looking cells, lobular carcinoma in situ, which sounds like cancer but isn't. If you've had a number of prior breast biopsies, even if they were negative, that can increase your risk. If you have dense breasts, and we'll get into that a little bit more in a second. Also, if you've had radiation to your chest before the age of 30, and that happens with patients with lymphoma who get radiation to their chest, and they are at increased risk because of that radiation. What I listed here is just a bunch of risk calculators. The Gale risk model, when at least at Capitol Health, when you get your mammogram and they say that they performed a risk model and to estimate your risk, they're using the Gale risk model. This is an American model that uses some of the things we discussed before about your estrogen exposure, as well as any relatives that might have cancer, but it only uses first degree relatives. So if you have a bunch of aunts and cousins with breast cancer, but your mom didn't have breast cancer, this isn't a good way for us to evaluate your risk. So here we use the Tyrer-Cuzick model. That's what we use in my office. This is a model that came out of the United Kingdom, and it allows us to put second and third degree relatives like aunts and cousins in there. These other ones are available for estimating risk of breast cancer, but we don't often use them. So we talked about who's high risks. If you have a known genetic mutation, if you have a family history that's suggestive of a genetic mutation, or if you have that lifetime risk of greater than 20%. And this is really important, and your life expectancy is greater than 10 years. So if you come to see me and you're 85 years old and we figure out that your lifetime risk is greater than 20%, we're not necessarily going to put you into high risk screening because if you're only going to live, let's say, another 4 or 5 years, we don't have any big nidus for us to do that screening. It's unlikely at that point, if you haven't already developed a breast cancer from your family history, that you're going to. So you sort of like beat the odds at that point. So we talked about this a little bit. I'll actually skip this one. It's a little bit of a repeat. So what can we do to reduce your risk once we know that you're high risk? So we can use risk reducing agents. And what I mean by that is medications that can reduce your risk. So it's actually the same medications that we use to treat breast cancer are anti-estrogen pills. And specifically, we're talking about tamoxifen and some of the aromatase inhibitors. You can have surgery. People think that if they do mastectomies, and that's removing the breast on both sides, that they reduce their risk to zero, but that's not true. We have to leave skin behind, and that skin can be very closely related to the breast tissue. And so the risk only goes down to about 2% per breast when we do mastectomies. And other things that you can do is have a healthy lifestyle. So limit the amount of alcohol you have to less than 1 drink per day. Really, we recommend less than 3 per week. Exercise, control your weight, and breastfeeding can decrease your risk of breast cancer. I'm just going to check the chat real quick because I just want to make sure. Okay, we're good. I just wanted to make sure there wasn't anybody saying they couldn't hear. Okay, so what is a mammogram? I'm sure a bunch of people on here have had mammograms already, but essentially it's an X-ray of the breast. Prior to 2000 and I think it was 11 or 12, these were done just in a 2D fashion, meaning that the beams were sent from one end to the other end and one picture was taken. The two kinds of views that we do, they're called CC, craniocaudal, that means from your head to your tail, so top to bottom, and then the other one is MLO, medial lateral oblique, and so that means side to side, and then the oblique means that we angle it a little bit. So those are the two views that we get. And then what we do nowadays, for the most part, is that we do 3D mammograms. 3D mammograms take pictures. They take an array of pictures in an arc, and then that allows us to scroll through the tissue up and down, and we see a little bit better. It actually picks up 40% more breast cancers than 2D mammograms. So pretty standard that we do 3D mammograms on everybody. Really, the only people who should be getting 2D mammograms are patients who are older and have very fatty breast. So these are the pictures of a mammogram. The top one is the medial lateral oblique, and then the bottom ones are the CC, so the squish up and down. And you can see in the medial lateral oblique, this is a really good mammogram. And the reason why is like in the middle part here where you see this white stuff, that's the pectoralis muscle. So you know you've had a good mammogram and the tech did a good job when you can see that pectoralis muscle in the picture. That's why it hurts so much. So something that's really important, sometimes patients will say to me, hey, can I skip the mammogram and just get an ultrasound or an MRI? And mammography is actually the only imaging modality that has been proven to decrease death from breast cancer. And that's because we diagnose things early on mammograms, specifically DCIS, or ductal carcinoma in situ, which is our stage 0 cancer. Most of the time that gets diagnosed with calcifications, and those calcifications can't be seen with ultrasound and MRI. So we can use the other studies in conjunction with mammogram, but they're definitively not a replacement for mammogram. So things that are provided to you at the time of your screening mammogram is they will give you information about breast density. In the state of New Jersey, that law was passed in 2012, that it's mandatory for us to report your breast density on your mammogram report. And then at this institution, we will report your Gale risk model. So that gets calculated when you're in mammography. And that brings attention to either your gynecologist or your primary care that you might be high risk and need to be placed into the high risk program. So these pictures here going from left to right show the 4 different kinds of density of the breast. And it goes A, B, C, D. And it goes from an entirely fatty breast to an extremely dense breast. And so when you're looking at these pictures, so all the little squiggly lines are 2 different things. They're blood vessels as well as connective tissue supporting the breast. And so what you'll notice over time is that connective tissue goes away. That's why as you get older, you get droopy breasts. But what's important here is that the fat in these mammograms is black and the breast tissue is white. And then if we look at these pictures down the bottom here, you can see that this is a tumor. So cancers show up as white on mammograms. So you can imagine if you're looking at a fatty breast versus a dense breast, that it's going to be pretty easy to find a tumor in a very fatty breast because it's looking, you know, the contrast between the black and the white, versus looking for a cancer in a very dense breast can be very difficult. The radiologist might miss it. So what's a breast ultrasound? So an ultrasound only uses sound waves. There's no X-ray to this. There's no radiation. And what happens is the sound waves bounce off that little probe and they bounce off the tissue and they return back to the transducer. So for the most part, we use this to work up problems. Now for screening, although when those laws passed in 2012, that we needed to report breast density, the state of New Jersey, as well as some other states, made some recommendations that we should be doing screening ultrasounds. So the only problem with screening ultrasounds is that there's a high false positive rate. And what that means is that we do an ultrasound, we find things and we put needles in them and they're negative. And so in other words, the ultrasound overcalls things. So these are pictures here of different things we see on ultrasound. So this is a cyst. And essentially the reason you get, so the ultrasound waves are coming in like this, bouncing back and forth. And the reason you get this white highlight after the ultrasound waves hit the cyst is because when it hits fluid, those waves speed up. And so it makes this white shiny thing afterwards. We call that posterior acoustic enhancement. And then here, this is a cancer. And you can kind of tell the difference between the ultrasound and the cancer in that the cyst and the cancer, in that the cyst has a really nice smooth border and this cancer has a very jagged border. And that means it's sort of like infiltrating into the tissue. And the end of the mass actually ends here. And then this is shadowing because those ultrasound waves hit that mass and then they can no longer get through. And so you get a shadow beyond it. So those are hints to us on ultrasound that something might be cancerous. This big thing here is a fibroadenoma. Again, really smooth borders. This is solid versus cystic. This is fluid. This is not fluid. So that's just differences in the way ultrasounds look. So when do we get ultrasounds? To look further at something that we see on mammogram. If you have something that's palpable and the mammogram's negative, we're going to get an ultrasound. Again, if you have a abnormal MRI, we'll get an ultrasound to see what's there. If there's somebody who has implants who it's very difficult to get a mammogram because they don't have a lot of breast tissue, we'll get an ultrasound. And then we talked about we could use it in screening for patients with either category C or D, heterogeneously dense or extremely dense breast tissue. We can also use it to help us figure out what we need to target for biopsy. So what's a breast MRI? Again, no radiation here. We use a magnet and some dye. Some people ask if they can have an MRI without the dye. The answer to that is no. And then also if we can do it open. And again, unfortunately, the answer to that is no. The breast MRI machine, the coil that you need in the MRI machine only works in a closed MRI. And the way this works is that we give you the dye called gadolinium, and then it shows us the pattern of the vascular system or the arteries. And breast cancer is, well, cancer in general is sneaky. And so what it does is it sends signals to your body to grow blood vessels into it so that it can get more of the stuff it needs to grow. So on this MRI here, you can see this is a cancer here, and you can see if you compare this is, I know it's backwards, but the left side to the right side, you can see there's all these extra vessels. And so this giant vessel, that tumor communicated with your body and said, hey, grow a giant vessel to feed me. And so you see there's another one over here and another one here, and that's called angiogenesis. And so what the breast MRI is showing us is increased areas of blood flow, or hyperactivity. And that's how we use the MRI to both diagnose and then assess size for cancer. We can also use it to work up high-risk patients. We can use it, discordant means where the mammogram and the ultrasound don't match up. So if there's something on mammogram and we can't find it on ultrasound or vice versa, and we don't have a good target for biopsy, we'll order an MRI, and we also use it to work up patients with breast cancer. So this here shows us the incidence of breast cancer. A lot of people think that the incidence of breast cancer is increasing, and it's not. More people have breast cancer now than they did years ago, not because the incidence is increasing, but because the population is increasing. And so when you actually compare it to the normal population, you can see that it's pretty steady. And then this is broken down by different races. And then here you can see this is actually the death rate or survival. And what you can see is that from 1999 until present, that death rate's actually going down. And that's because our treatments are better, we're diagnosing earlier. And so survival at this point is much better than it was. And this only goes to 2013. But survival is much better than it used to be with all the new drugs that we have. So how is breast cancer diagnosed? So we biopsy it, we put a needle in, we look under the microscope, and that can be done with the different imaging modalities that we've spoken about. We'll quickly go through this. This is like maybe a little bit too much information, but essentially what this picture here is showing you is the breast picture that we looked at before with the lobules and the ducts. And then this is a breakdown of the ducts of what a normal duct looks like with one cell layer. And then we start to get overgrowth of cells. The cells look funny. They start to look like cancer. And then invasive cancer, meaning that the cells started to sneak out. There's different types of breast cancer, and then the grade, if you ever hear about grade, tells us how quickly or slowly the cancer cells are dividing. We look at, like, do they look pretty normal looking and uniform, or do they look pretty erratic and crazy? And the sort of like crazier they look, it means they're dividing so fast that they're not able to develop into a normal looking cell. So that means it's a more aggressive or faster growing cancer. We look at receptors, estrogen, progesterone, and HER2, which are proteins in your body. And we ask, like, are the tumors feeding off of these proteins? And that helps us determine targeted therapy. Can we give you an anti-estrogen pill? Can we give you a drug called Herceptin? Ki67 is a proliferation marker. It's a percentage, and then it tells us, it's similar to grade. It tells us how quickly the cells are dividing. We don't happen to order that at our institution just because it doesn't give us any information that's going to be useful for treatment, but some institutions order it. So breast cancer can go from stage 0 to stage 4. Stage 0 is the earliest you can be diagnosed DCIS with 100% survival. These patients don't need chemotherapy. And then essentially, we'll go to the next one to show, but we start off like a stage 0 and then a stage 1, meaning small tumor not in the lymph node. Stage 2, we're getting bigger tumors that go to the lymph node. Stage 3, even more lymph node involvement. And then stage 4, meaning it's spread elsewhere outside of the breast and the lymph nodes into either like lung, liver, brain, bone. So depending on what kind of cancer you have determines the treatment. Can we do a lumpectomy where we only remove the cancer with some healthy tissue around it? Or do you need a mastectomy where we remove the whole breast? And that depends on how big the cancer is, your genetic history, those sorts of things. And then lymph nodes, do we have to take out all the lymph nodes, or can we just take out a few lymph nodes? This is picturing what a sentinel lymph node biopsy is, where we inject a dye into the breast, and then we only take out the lymph nodes with a dye, and then if those are negative, we remove fewer lymph nodes. The benefit of just doing a sentinel node instead of an axillary dissection is that you can get significant swelling in the arm after we take out lymph nodes, and it's much less with a sentinel node than an axillary dissection. Then we talk about reconstruction. If you've had a mastectomy, there's implant-based reconstruction. There's using your tissue. So this is a patient here on the left who had nipple-sparing mastectomy. So that's all of her breast tissue is gone, and she just has implants in place. But we have some cool things that plastic surgeons can do, where they can take tissue from your belly, they can take tissue from your back to make things back to, look as normal as we can. And then, so I know this is an awful picture, but this is what happened. This is like what happened 30, 40 years ago. We were doing this to everybody. You had a 1 centimeter or a millimeter or 2 millimeter tumor. This is what people were having done to them. And now this is a patient below who had a bilateral mastectomy and looks pretty normal. So chemotherapy, it just depends on the kind of cancer you have. Anti-estrogen therapy, we call it chemotherapy only because it's a drug that treats cancer, but it doesn't make you lose your hair or make you sick. But that's a pill that somebody would stay on for 5 to 10 years if they need it. And then IV chemotherapy and Herceptin, those are IV medications that can make you sick. Again, we only give you these medications if you need it. Radiation, what radiation is that we take charged particles and we send them in a big beam. This is called down below a linear accelerator. And that beam goes from one end to the other end, and your breast is in the middle of it. And you can see here how these beams go through, and all of these colored lines here are how the radiation oncologist and the physicist and the dosimetrist figure out your plan. These lines will tell them what the dose of radiation is. And what they're trying to do is minimize the dose to the skin, minimize the dose back here, because if a beam's coming through, it can treat your lungs or your heart if it's in there, and really concentrate on the breast tissue. And usually with radiation, there's a week that you get what's called a boost, and that's to the tumor bed. This is really old balloon-based partial breast radiation, where we only radiate a centimeter out from the tumor. We don't really do this much anymore. We do it, but we use these big machines. We don't do it with the balloons anymore because the balloons are uncomfortable. And then intraoperative radiation therapy, we don't do that here. We don't have any long-term data on this. It's not been around long enough for us to know really what the recurrence rates are, but that's when we have a big machine in the operating room and you get radiation right there. We talked about this. Did I go backwards? No, okay. forgot to delete a slide. So lymphedema, this is when you have lymph nodes out. You can get lymphedema, which is swelling of the arm. We try really hard to avoid this if we can by just doing a sentinel node and not an axillary dissection, but sometimes it just happens. There are newer surgeries that are coming up where the breast surgeon, while they're doing an axillary dissection, can try to save, but it's on a microscopic level, try to save the lymph nodes, or I'm sorry, the lymphatics coming from the arm, and then the plastic surgeon comes in and sews those lymphatics to the veins to sort of bypass the missing lymph nodes. This is really up and coming, something that I hope we can do here soon. I was actually just talking to our plastic surgeon about introducing it. The big major academic centers are just starting to do this, so I'm hoping we'll have that trickle down effect where we can start doing this soon. I'll have to get myself a pair of glasses with magnifying glasses on them. So the definition of a breast cancer survivor. So someone who it's from the time of their diagnosis through the rest of their life. People always ask me, like, when do I say I'm cancer-free and I'm a survivor? And truthfully, it's up to you. There's no rhyme or reason to when it is. So whatever you feel that point is. And family members and friends and caregivers are also impacted by a breast cancer diagnosis. There can be impact on the patient's health, their physical and mental state, their identity, sexuality, financial standing. There are so many things that go into breast cancer survivorship. And this is how many survivors there are. And so if you look, there's 18 million breast cancer survivors, which is a lot. And like going back to 1977, you can see there's only probably about 3.8 million. So there are a lot of breast cancer survivors out there. And truth be told, that's why breast cancer is one of the most researched cancers in the United States, because there's so many survivors who are raising money and really encouraging researchers to find a cure, find out how it's happening, stop it from happening, all those sorts of things. But any survivors who are on this Zoom meeting, you are among 18 million breast cancer survivors. And you can see, so this goes back to 2012, but essentially, this is the survivorship statistics for breast. So this is a long time ago. Obviously, there's a lot more right now. And breast cancer, of all the different cancers, has the most survivors. And so what do you do in survivorship? You have to monitor for cancer recurrence. You have to manage the complications from the treatments that you have. You have to promote good health and coordination of care if you do have any complications from treatment. And so what I'm going to do, so I'll stop here. I'll stop share on this and you guys can see my face and see before we move on to LuAnne, if anybody has any questions.
So if people have questions, probably the easiest thing to do would be to put them in the chat box, if you can do that. Otherwise, you can go to your reactions button and you can raise your hand. That's another option. Here we go. Do you want me to read them off, or do you want to just?
No, I can read it. That's fine. I got it.
Okay.
So Carol asked, what determines chemo before or after surgery? So a couple things. It truly depends on the receptors. That's where it comes up first. So when we talk about estrogen, progesterone, and HER2, for the most part, and I will say this again, everybody has an individual treatment plan. For the most part, patients who are estrogen positive and HER2 negative will not have treatment up front. They'll have surgery first. But just as an example, I have a patient now who has a pretty big cancer that's estrogen positive and HER2 negative, and she really wants a lumpectomy, and I can't do one right now. So I'm going to put her on an anti-estrogen pill for quite some time to see if I can shrink it down. But as far as chemo goes, usually it's if you are HER2 positive and your tumor is above 2 centimeters, you'll have chemotherapy first. And if you are triple negative, the estrogen, progesterone, and HER2 are negative, and your tumor is greater than 1 centimeter, you'll have chemotherapy first. And the reason we do that, not always necessarily to make it easier to do a lumpectomy. We do it sometimes if it's in the lymph nodes to try to switch you from having an axillary dissection to a sentinel node. But really the reason we do it is to make sure our drugs are working. So if we give you those drugs up front, we can check to see at final pathology if the tumor has had a response. And the way that looks is either less tumor or no tumor at all. And all at surgery, all that's left is scar tissue. And then we know the drugs that we gave you worked. And then if they didn't work, we actually either give you additional medications or switch your medications after surgery, because we know that you'll have a survival benefit if we have to switch things. So question, would you recommend hormone testing specifically for high estrogen levels? Not necessarily. It's really about whether you're in menopause or out of menopause. That really what tells us which medications that you can be put on, whether it's tamoxifen, which is used in the premenopausal patients, or aromatase inhibitors in the postmenopausal patients. And then you can take somebody who's premenopausal and give them tamoxifen, as well as something called Lupron, which shuts their ovaries down. And then give them a different medication. So, but there's no reason, like, it's not like you would have your estrogen levels checked as sort of like a way to see if you're at higher risk of breast cancer. That's not a standard that we do right now. Maybe in the future somebody will, but as of right now, we don't do that. What is considered an older age of menopause? So usually like average age of menopause is 50. So, you know, when I know patients who are in their mid 60s and haven't gone through menopause yet. So that's definitely considered a higher age, but usually on average it's 50. As far as monitoring for once you're in survivorship, so obviously doing mammogram. There are some more recent recommendations that if you still have your breast, it depends if you have your breast or you don't have your breast, but if you still have your breast, in addition to doing mammogram once a year, you can also, if you have dense breast tissue and a breast cancer diagnosis, you can also do MRI once a year. And then beyond that, you're looking for systemic symptoms. So bony pain, headaches, difficulty breathing, or cough that won't go away. And then you let your medical oncologist know about those things. There's no, as of right now, the National Cancer Guidelines do not recommend sending any cancer tumor markers, which are numbers like in your bloodstream of tumor burden. Those aren't shown to be effective at monitoring for metastatic disease or recurrence. And then there's also no known benefit to doing screening imaging on people. In other words, like getting CAT scans or PET scans to see if there's a recurrence. There's no benefit to that. And in fact, those studies, by getting CAT scans once a year, say you're increasing your exposure to radiation, actually increasing your overall risk of cancer. Dense breast, would you, yeah. So the question is, if your BRCA test was negative, but risk factor is greater than 20% with dense breasts, would you recommend MRIs with mammograms? Absolutely. And on top of that, you don't even need dense breast tissue. So if your lifetime risk of getting breast cancer is greater than 20%, insurance is required to pay for a mammogram and an MRI, regardless of your breast density. So you actually asked a quite controversial topic that I've been going over with the OB-GYNs, because the state of Pennsylvania just released information that if you have extremely dense breast tissue, so category D, that insurance is required in the state of Pennsylvania to pay for a mammogram and an MRI once a year. And then they recommend with category C breasts that if you have category C plus one risk factor, so you have category C breast and your aunt had breast cancer, that also insurance is required to pay for an MRI. But that's completely separate from your risk of breast cancer. That's just based on breast density. So question is, you had said that not having children is a risk factor. Does that increase risk of recurrence? So the answer is no. It increases your risk of getting breast cancer, because essentially when you're pregnant, your estrogen levels drop. So it's, again, the overall exposure to estrogen in your lifetime, but it does not increase your risk of having a recurrence, because most of the time, like especially if you're estrogen positive, you're going to be on anti-estrogen therapy. So yeah, your recurrence risk does not increase. Let me see if I missed anything. Nope, I think I got it.
Okay, great. Thank you so much, Dr. Allen. We really appreciate it.
Of course, and thank you everyone for the great questions.
Yeah, they were. Thank you very much. Okay, so we're going to move on to LuAnne now. Thank you very much, LuAnne. You can get started.
Okay. Thank you for having me. My name's LuAnne. I'm from Oasis Salon and Wellness Spa, and I was not able to get my video working for today.
For the screen share, LuAnne, do you want me to run that?
Screen share?
The screen share.
Oh, yes. I'm sorry. I thought I had it up. Okay.
I don't see it. Ah, there you go. There you go.
Am I here now?
Oh.
Thank you. Thank you. So I'll go over some of the cancer care services that we have available at Oasis Spa. One of them is the Just For You Wig Boutique, and it is a wig boutique that is based in East Hanover, New Jersey, and this is a satellite branch here in Capitol Health within the spa. So we have different kinds of wigs, and we have different hats and scarves, etc., that we can help you with. And I'll go into more detail in a minute or two. We also provide a set of eyebrows with when you pick your wig up. So the eyebrows are basic, they're tattoos that you place on yourself. I teach you how to do it, and they do last for about 5 to 7 days. We also have post-surgical bras, which are the basic post-surgical bras for after you have your surgery, and you can change from the bra that you have placed on you at surgery. We also have manual lymph drainage, and this is not for what we saw earlier. If you have the lymph nodes removed and then you have the lymphatic arms, that is the one that we provide is for if you've had a surgery and some sort, and the doctor recommends you have manual lymph drainage. So what that does is it helps to reduce the swelling, it moves the lymph fluid around, and it helps you to heal. We also have special protocol for our services for those with a weakened immune system. The best example I can give for that is for our nail services. If you have a weakened immune system and you would like to have a manicure or pedicure, it's really important to be careful that you go somewhere where they use disposable implements, which is what we do here. If you go to a regular nail salon, you'll probably notice that it looks like the emery boards have been used several times, or maybe go to cut your cuticles, and there's a few things like that that you should not be doing when you have a weakened immune system. We also have massages to promote stress reduction and pain management. We have the Daisy Makeover, which we'll talk about in a little while. And we also have oncology massage, which our massage therapists are certified, trained and certified to have, be able to provide this service. And the oncology massages are customized for each client's specific needs, and they're very helpful. They can help reduce pain, fatigue, nausea, depression, anxiety. And if you have received chemo or radiation in the past 6 months, we recommend that you ask your doctor if it's okay for you to have a massage. We also have a neroli facial in our menu, which is a specific facial for people who have sensitive skin or skin-related side effects from cancer treatments. We use soothing products, and it helps to hydrate your skin. It helps you relax and helps to uplift your spirit. And we use neroli with it. It's the extract of bitter orange blossom. We also have Reiki services and reflexology services. Additionally, we have bedside services. So if you are in the hospital, if you're admitted to the hospital for any reason, and you would like us to come to help you feel better, we are able to do that as long as your doctor says that we can come to do that for you. Another couple of services that are very new to us, we have the massage treatments that we currently provide in the infusion room. And for that service, we can do a comfort massage, which is basically we can do a massage on your hands, your arms, or your scalp, whichever you prefer, while you're wearing a heated neck wrap. And then we also can do Reiki and reflexology in the infusion room. We are going to begin doing that for the radiation patients very soon as well. So the Just For You Center is the wig boutique located, up in East Hanover, New Jersey. And it's actually been there for about 30 years now. And so we offer wigs and accessories, wig cutting and styling, transitional hair services, if you'd like to have a transitional haircut. And we also do the insurance paperwork for you. So if you come here to have a wig consultation, it's confidential, no obligation. We have the private room for you, so it would just be yourself and myself in the room, and we do the fitting and the consultation there. Then we would order your wig for you. It typically takes about 7 to 10 days, and when it comes in, basically I will help you. I will teach you how to wear the wig, how to take care of the wig, and how to wash the wig. And you would receive a wig drying stand, a mannequin head, and ongoing professional support. So we have human hair blends and synthetics. We have different wraps and hats, scarves. We have hair pieces. One popular hair piece is called the halo, and it fits over top of your head. And a lot of people like this if they wear hats regularly and they have a collection of hats. So the halo basically is a band that goes the top of your forehead to around the top of your ears, and it's circular, and the hair is attached to that. So there's not actually hair on the top like a full wig. It's very popular for people who to wear hats on a regular basis. Some benefits of massage are that it boosts your immune system, it helps improve your sleep, it helps decrease nerve pain, helps relieve migraines and headaches, and it also helps to ease joint pain. Basically, all of our services in Oasis Spa do include some form of a massage. Another program we have is the Daisy Makeover, and this is a makeover where we invite you to come, and myself and Svetlana, we help you to highlight your natural features so that if you look your best, basically you'll feel your best. So we just talk about how to enhance your natural features on days that maybe you don't feel as well. You'll also receive a makeup kit. So you get a nice little makeup kit. We'll teach you about some beauty products that you should stay away from. We'll also teach you about natural cleaning solvents that you can use instead of using things from out on the market. Fashion tips and ideas. We show how you can wear very comfortable clothing and still look great. And then we talk about hats, scarves, and wigs as well. And we usually end it with a meditation or a little chair yoga session, and that's it. So, do you have any questions?
Yeah, LuAnne, actually, I was going to hold them till the end, but I know that you may not be here, so I just wanted to double check because I think somebody just had a question. How is the facial different from others? I haven't had a facial in a long time. So maybe that's,
So the neroli facial is a very gentle facial. We only use soothing products for that. We don't provide any type of exfoliation or any kind of appeal with this facial. It's a very soothing treatment, and the neroli oil helps to soothe you and your skin.
so I think that's it for questions. So thank you so much, LuAnne. We really appreciate that you came. You offer some wonderful services there. And I'm going to introduce Maureen now, who will be leading a yoga session.
So we'll just go through a body scan and calm the muscles and relax the chest. We will then do a little bit of breath work, which is how I start every yoga class. And then we'll just do a couple light movements that we can do sitting in our chairs, so you don't have to stand up or lay down. You can just relax a little bit. So we'll begin with a body scan. So the first thing that we'll do is take a nice deep breath in through the nose and exhale through the mouth. And one more deep breath in through the nose and exhale through the mouth. And gently close your eyes. We'll begin by relaxing our toes. Relaxing the soles of our feet. Relaxing the ankles. Relaxing the heels. Relaxing the shins. Relaxing the calves. Relaxing the knees. Relaxing the backs, the hamstrings. Relaxing the thighs. Relaxing the hip bones and the sits bones. Relaxing the lower belly. Relaxing the lower back. Relaxing the chest. Relaxing the upper back. Relaxing the shoulders. Relaxing the tops of the arms. Relaxing the elbows. Relaxing the forearms. Relaxing the wrists, the palms, the fingers, and the thumbs. Just let them rest in your lap. Relaxing the throat. Relaxing the back of the neck. Relaxing the back of the head. And then gently relaxing each of the muscles in your face, just letting the tongue fall to the bottom of the mouth so that we're not clenching our jaw. And just notice if there's any tension in the body. And if so, gently breathe into that space and gently let it go. We'll do a little bit of breath work. So we're going to do what's called a box breath. You can keep your eyes closed. We'll breathe in for 4, hold for 4, exhale for 4, and then hold again for 4. And we'll repeat that 10 times. So take a cleansing breath in through the nose and exhale through the mouth. We'll breathe in, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4. Inhale, 2, 3, 4, hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Just return to your natural breath. And we'll begin by bringing the chin down to the chest. And we're going to rotate our neck in a clockwise motion. Inhaling as the chin comes forward. And exhaling as the chin goes back. Nice, slow, deliberate motion. Inhaling and exhaling. And the next time the chin comes to the chest, we'll rotate in a counterclockwise motion. Inhaling as the chin comes forward and exhaling as the chin goes back. And the next time the chin comes to the chest, we'll just raise our gaze, taking our right hand onto the left side of our head, pressing our right ear down towards our right shoulder, feeling a nice stretch in the neck on the left side. And we'll release the right hand, taking the left hand onto the right side of the head, pressing the left ear down towards the left shoulder, feeling that same stretch on the neck on the right side. And releasing both hands. We'll lift both hands up towards the ceiling. We're going to bring our right hand down towards our back, grabbing onto our elbow. We're bringing it up towards the center of our head, feeling a nice stretch in the tricep. And we'll reach up, placing our left hand down, grabbing onto our left elbow and bringing it towards the center of our head. And we'll reach our arms up towards the ceiling. We'll bring our arms down, reaching them out shoulder height, palms are facing the ceiling. We're bringing our shoulders down away from our ears and bringing our hands just behind our shoulders, feeling a nice stretch through the chest and lifting the chin up just a little bit to deepen the stretch. And give yourself a nice big hug. And we'll open our palms up towards the ceiling again, keeping the shoulders down away from the ears, lifting the chin towards the ceiling. Good. And we'll bring our arms out in front, and then we'll flip our palms over so our palms are touching, and then pulling our shoulders forward, feeling a nice stretch in the upper back. And we'll bring our hands down onto our laps. And just like we did with our neck, we're going to lean our chest forward and we're going to rotate in a clockwise motion, opening up the hip flexors just a little bit. And the next time we come to center, we'll rotate in a counterclockwise motion. And the next time we come to center, we'll come back to a neutral spine. And we're going to take our right hand over towards our left knee, bringing our left hand behind us and twisting open towards that left shoulder. And we can gaze over that shoulder. And we'll come back to center, taking our left hand onto our right knee, twisting open towards the right shoulder. And we'll come back to center, reaching our right arm up towards the ceiling, leaning over towards the left side, Feeling a nice stretch in the right side of the body. And we'll come back to center, reaching the left arm up, reaching over towards the right side. Feeling a nice stretch in the left side of the body. And we'll come back to neutral. We're going to bring our right hand out in front, flexing our fingers up and then bringing them back towards our face just a little bit to open up the wrist. We spend a lot of time doing this and doing this. We need to open up the wrist just a little bit. And then we'll switch sides, the other hand. Good. That's all I have for you ladies tonight. Thank you for letting me share the time with you.
Thank you very much, Maureen. That was a nice, relaxing way to end the program tonight. We appreciate your time and coming tonight.